Hello, welcome everyone to the Women Project's panel in honor of Abortion Provider Appreciation Day. We're so excited to have you with us. This is building on a conversation, we started about a year ago with the introduction of the Equality in Abortion Coverage Act, but then also on Monday with a panel for International Women's Day, looking at abortion coverage, the Medicaid program, and economic justice. Today, we're continuing that conversation, talking with some Rhode Island health professionals and a fantastic Colorado health advocate who's going to talk to us about how abortion coverage links to maternal health. And we'll also be talking about how bans on abortion coverage undermine efforts to try to advance health equity and racial justice. We picked today to have this conversation because March 10th is known as Abortion Provider Appreciation Day. And while we talk about celebrating, the original marking of this day comes from a very horrific anniversary. On March 10th, 1993, an abortion provider, Dr. David Gunn, was murdered by a white supremacist anti-abortion extremist. And a day was created to honor him in 1996 and also to honor providers who had been killed in the years since, and also to really start a conversation about the violence and extremism of the anti-abortion movement. In the years since, it has become a day more of affirmation for the health professionals, doctors, clinic staff, nurses, escorts, everyone who works so hard to ensure that when someone needs an abortion, they can get one. And so we're really coming at this from that affirmational place, and also to talk about the work that is still needing to be done to really, truly honor the provision of abortion, those who do the providing of care and those who are seeking care. And so we're going to have this conversation today to build on the campaign that's going on in Rhode Island specifically to get rid of the bans on health coverage for abortion for people who use Medicaid and for state employees, and to talk about efforts around the country, the pressure that needs to continue to be put on President Biden, who made a campaign promise to get rid of the Hyde Amendment when he was trying to get elected. And this is the federal policy that takes abortion coverage away in a wide range of public health and programs regulated by the federal government. But let's also talk about the other kind of work that needs to be done, like Karla's organization that's advancing a bill to ensure that undocumented people can get access to contraception, and that the state Medicaid program really enhances access to contraception. All of these discussions are so important, and they are an active, concrete way that we can live up to our values and that we can honor both health professionals and individuals who believe that every person should decide for themselves what happens with their body, what kind of health care they need, is able to plan their families and control their futures, because that's really what it's all about. So let's go ahead. We're going to kick off this conversation today with Dr. Jennifer Buckley, who's with the Rhode Island Academy of Family Physicians. So Jen, why don't you kick us off?
Hi, everyone. Thanks for having me, Morgan. I guess I first just wanted to talk a little bit about the legacy of health professionals and what we've been doing to advocate for access to care. And by doing that, I first just wanted to talk a little bit about what family medicine is. So I'm a local family medicine doctor in Rhode Island, as is Julie. We actually both went to the same residency program, the Brown Family Medicine program. And so historically speaking, family doctors in Rhode Island and across the US have long been a part of advocating for reproductive choice and then also providing access to that choice. As family doctors, we take care of everything. So we take care of the full person, all ages, hypertension, diabetes, gender care, substance use treatment, pregnancy care, contraceptive care, abortion care, mental health, rashes, well care. The list goes on and on and on. And so I say that in the setting of when we're specifically talking about abortion, abortion is something that we do as family medicine, just in the realm of what we do in the larger picture. And so we see this as something that should be available just in the general scope of the primary care setting. And of course, being available, it also ties into the bill that is ongoing in Rhode Island right now in the setting of access from an insurance standpoint. So specifically, if we talk a little bit about the Brown Family Medicine program in Rhode Island, the program is constantly recruiting and training family medicine doctors to do all of the things that I just talked about above, including becoming abortion providers and supporting reproductive health access in Rhode Island. There's other organizations like the American College of Obstetrician and Gynecologists and the American College of Nursing Midwives who are also very much advocates for this particular issue. In Rhode Island, we also have something called a reproductive health cluster. And it's pretty unique because it's not just family doctors. We also have some internal medicine doctors too, which is really great to involve two specialties in this cluster. And our cluster is supported by this larger group in the US called the Reproductive Health Access Project, or otherwise termed RAP. And so within this group, basically we're a bunch of physicians who are getting together to work towards both providing abortion care and advocating for change in Rhode Island and getting behind these bills. It's also been a really great support network when it comes to barriers and obstacles to care, and a place that we oftentimes brainstorm. The other thing that I wanted to talk a little bit about is obviously we're all in the midst of this pandemic, and there's been a lot of challenges in this pandemic, but a big push that has come out of the pandemic is that there's been major physician specialties, including our very own, the American Academy of Family Physicians, who are really advocating for removing the REMS classification from mifepristone, because as everyone here I'm sure already knows, mifepristone is a very safe medication. And then this has also opened up the pathway to telemedicine medication abortion, which is something that we're also moving forward with in Rhode Island. So, you know, if we're in putting on our equity lens, you know, as everyone here knows, to force someone to have to physically go into an office to pick up a medication it's an unjust and discriminatory burden, and it disproportionately impacts women of color and women in lower socioeconomic brackets. And these tend to be the communities that have been hit hardest by COVID-19. So I just wanted to start with a little bit of background on that.
Well, that makes a lot of sense. And thanks for highlighting that lawsuit. You know, it's an important part of the discussion of really talking about the fact that even in a state like Rhode Island, where actions were taken a couple of years ago to affirm and protect the right to abortion, or I'm here in Maryland, we have pretty strong laws, Karla's out in Colorado. But when it comes down to it, the right isn't enough. It's not real if people can't get access to care. And in a pandemic, when there's been a lot of conversation about essential health care, there have also been a lot of political attacks trying to claim that abortion is not essential health care. And so that's been a real organizing need. And part of that has been pushing back on what you were just talking about, Jen, on the limitations that exist in the Food and Drug Administration and their FDA. Got that all messed up in my head a little. Anyway, I was like, do I acronym? Do I say it? Anywho, there are limitations on abortion pills that do not exist for other medication in terms of how it's accessed. And so the pandemic and the need offered an opportunity to have that conversation, and that requirement for folks to pick up those pills in person was temporarily removed, but has been imposed again. And there's an ongoing lawsuit that Sister Song, the National Women of Color Reproductive Collective, has been part of and continues to be part of, along with the ACLU and other advocates, to try to get rid of that requirement. And so thank you for lifting that up, because it emphasizes that those barriers always fall hardest on those who already struggle to obtain healthcare, either because of systemic obstacles or financial barriers, or in the case of a global health crisis, literally a threat to life and health of being forced to go into an office or try to access these pills. And so we're talking about dignity, but we're also talking about equity and health, right? And the Women Project, who's hosting this conversation and bringing us all together today, really wants to make sure that when we talk about abortion, we do talk about it in the context of all of those important intersections. You know, the Women Project really grew out of the Reproductive Privacy Act, that legislation to protect the right. But then the work since has really dug in on, but what are the barriers that push that right away? So organizing and standing up last summer around racial justice, ending police violence, and really the right to parent your children in a safe and healthy environment, talking about health equity. And that's what we're hoping that Julie, Dr. Blossom-Hartley, can talk to us a little bit more about that link to health equity.
Yeah, I wanted to piggyback off of something that I think Dr. Buckley was emphasizing, which is that the legacy of family medicine physicians, which both of us are, but also in medicine has been, I think, a trend towards the more political. I think medicine has, you know, in certain ways throughout history been involved in pushing policy, but I think more and more, and the pandemic has made this even more salient, that as physicians and people in medicine, we also need to be well aware of our local governance, our local policies, and what things are affecting our patients. The more that we've sort of learned and focused on in our training, social determinants of health and what types of life circumstances also affect people's health, I think we've become more aware and become more passionate about these types of things. And so I do, I think here in Rhode Island, the family medicine residencies and a lot of the other residencies, honestly, have started focusing more on advocacy and how to sort of push forward the things that will help our patients the most. So I just wanted to sort of drive that home, that is something that doctors should be involved in, that we should be paying attention to local legislation and federal legislation and advocating for our patients and really pushing for what's right, because the two are sort of inextricable. That you can't have the way that our healthcare system is set up, you can't have good healthcare without having good policy around healthcare. So one of the things that Dr. Buckley and I were reflecting on as we prepared for this panel with the guidance of the Women Project, we were considering, you know, what is essential healthcare and why has abortion sort of been left out of the essential, what is essential healthcare? Why has that been used as sort of a, well, we don't need to cover abortion, which is essentially what some of the legislation that we're discussing today talks about, is that, you know, people, state employees and people with state insurances don't currently have coverage for abortion. And we were thinking about it, and honestly, abortion is essential healthcare because it's a common and normal part of life. Just as sex is a normal part of life, and pregnancy is a normal part of life, and parenthood and menstruation and miscarriage and all of these other things that we care for as physicians, those are normal parts of life. And we really have to stop treating these topics as separate from usual healthcare. The reality is that 3 in 10 Americans will have an abortion by age 45. That's a huge number. And whether we're aware of it or not, as citizens, we all likely know someone who's had an unintended pregnancy and sought an abortion. These are our partners, our mothers, our sisters, our friends, acquaintances, coworkers. And like Jen was saying, as primary care doctors, we manage a lot of different conditions. So just to put that 3 in 10 number in perspective, that's actually higher than the rate of other common conditions like asthma, which is 1 in 13, or diabetes, which is 1 in 10. And we would never eliminate common conditions like asthma or diabetes from our scope of care, and we would never deem coverage of those conditions as non-essential. The thought of it simply is absurd. And abortion should really be no different. I think I feel confident saying that excluding abortion or calling it non-essential care is an absurd thought. It's something that is common and normal and that we should have coverage for everybody.
Well, thanks for that perspective. I mean, it really is so important. You know, even if someone personally feels like they wouldn't seek an abortion or has conflicted feelings about abortion, at the end of the day, whether it's a politician or an individual, we shouldn't be imposing our beliefs or personal feelings on the kind of healthcare other people can get. And there's a really powerful quote that you made me think of, Julie, and I wish I could think of who it was. I'll have to put it on our Women Project page after. But it's something like, there's not people who have an abortion and people who don't have an abortion. They're different people at different points in their lives. So, you know, as people are growing, and if we think from a reproductive justice, health and rights perspective and the kind of policies that we're advocating for sexuality education that's compassionate, that's comprehensive for young people to learn about their bodies and how to build healthy relationships and a healthy sex life. Then as people are getting older, we're trying to make sure there's access to contraception so that someone doesn't have to face an unintended pregnancy. We want to make sure that if someone does, that they get the option then to decide whether they want to choose adoption or seek abortion or become a parent or add to their family. And at the end of the day, with any of those decisions, you're going to need healthcare. If you're choosing adoption or adding to your family, you're going to need prenatal care. If you need an abortion or want an abortion, you're going to need healthcare. And we should ensure that people have affordable access to the services no matter what. And that's really what it's about at the end of the day. And we know that, as you alluded to, when we deny that access or put up so many barriers that only some people are able to get affordable care, it has a real health impact. And so Karla Gonzales Garcia from the Colorado Organization for Latina Opportunity and Reproductive Rights is here with us from Denver, Colorado. And she's going to talk with us a little bit about that very fact of how abortion and abortion coverage are intrinsically linked to maternal health, and also how these conversations we're having are also linked to women of color's health, racism and white supremacy, which we're having some real conversations about. And these issues are all connected. So Karla, take it away.
Thank you, Morgan. First of all, I want to honor and thank Dr. Buckley and also Dr. Blossom-Hartley. Thank you for all the work that you do and for trying to keep us safe in this kind of violent environment, correct? That still is trying to make sure that our bodies are coerced into Morgan, what Morgan said, correct? To pretty much coerce into not doing what we want to do for what is the best for ourselves and our families and our communities. So thank you both so much. As a person that had an abortion in a country that abortion is illegal, and that needed to borrow money from friends, making sure that I'm gonna have a provider that is going to keep me safe, because a friend of mine died from an unsafe abortion back at home in Peru. So I really, really, my sincere appreciation and gratitude to you both for doing the work. Thank you. So again, Karla Gonzales Garcia, Policy Director for Color, Her Health Ella. And I want to take us a step back to correct, because when we talk about all these policies passing around the country, different states that keep pretty much denying abortion care to our folks, it falls hardest the most on Black, Indigenous women of color. So as it does this, we are talking about racism. We are talking about white supremacy in itself. And when we talk about the history of white supremacy upon the bodies of women of color, we got to talk about in the process of colonization, how white supremacy here, how the white man was pretty much coming and raping indigenous women to take their land, how they were using them to get them pregnant so they can take the land from them. And then during the slave labor time, how white men were raping Black women in order to have children so they can become slaves themselves, so they can have the economic growth that they wanted, correct? So we are seeing this, and later on, the forced sterilizations upon the bodies of Latinas and indigenous women. And even here, living even in California a few years ago, the forced sterilization process in prisons in California. So this is still going on. And last year, the forced sterilization of undocumented women in detention centers. So we are talking about that coercion, the lack of reproductive freedom that we have in this society. And on top of that, they are still trying to like force us to not make decisions upon our bodies when they try to introduce these laws, trying to take away abortion access to us, correct? So we see this like this is a strategy, this is a tactic of white supremacy in order to keep women of color to the margins, in order to kill our bodies, our souls, our minds, and our spirits. This is constant. So the fact that people still can't see that because of their privilege, their skin privilege, the socioeconomic privilege, and there's some religious privilege. Because when you are a person of faith and you are trying to impose your belief system on others, that's privilege in itself, because you have the time and the resources to do so. But you are not even taking into consideration the people that are suffering right now or had those experiences and have to make hard decisions for themselves. So when we then like talk about how then it's like tied to the maternal health crisis, Colorado, for example, has faced an abortion ban last year, an abortion late in pregnancy ban. And Colorado came again, like this is the fifth time that we have defeating an abortion ban. So, and when people don't think about like, okay, what exactly is happening here? Why abortions later in pregnancy needs to be accessible? Like why here? Because women of color, first of all, do not have access to healthcare. Like just to think about the fact that, for example, during a pandemic, that we see how people of color are dying, and people are like, why people of color are dying? Don't you read the news? Don't you like talk to people? Don't you educate yourself when you have the privilege and accessibility to have like an internet at home and see how, for example, people of color haven't been accessing healthcare because this discriminatory and racist system has pushed us into the margins? And on top of that, you like the state and like the state violence, correct? The state violence trying to take away abortion services like away from us when already we don't have access to basic care. And then when our bodies, because of like the lack of like good food around our communities, the lack of like, not the lack, but the environmental racism around our communities, the lack of affordable prescription drugs, and all these things to take care of ourselves. And then we have complications because all of these systemic issues that are being placed upon our bodies, and we can't have access to like just basic health care, and then taking away this accessibility to abortion when we need to, like sometimes we have to make the hard decisions to make an abortion. So you all, like this is about coercion and this is about state violence. We like when we are seeing, like, for example, Roe v. Wade. Let's talk about Roe v. Wade here. Legality doesn't mean accessibility. Our communities of color, when you go and dig in, all these like fake clinics, these crisis pregnancy centers are around communities of color. And then when you do not even have the basic health insurance, how the hell are you going to take care of your body and your baby? And when you are already under low income wages or like jobs that do not protect or do not have workplace policies that we can take care of the time, we can take care of the time to take care of ourselves, our babies, how the hell then we are going to leave the cycle of poverty? This is all about like keeping us down. And this is how like our communities, Latinx, Black communities, Indigenous communities, Asian Pacific Islander communities, how all these communities, we have been like pushing to the margins and literally not be able for us to exercise power upon our bodies, because this society keeps telling us that we can't do that. And the fact is, providers like Dr. Buckley and Dr. Blossom-Hartley are here to help us out and keep us safe. Because a lot of times it is a life or death decision to make the decision to have abortion. And they are here to make sure that we are safe and protected when we do that. Black women in this country are like 3 to 4 times likely to die at birth. here in Colorado, indigenous women die 4 times more at birth than white women. And we still, like the systems still hear white people about how we should treat this when it is an issue that the community voices should be at the center when we are trying to tackle these issues in our communities. And on top of that, we still have here in Colorado people that tries to deny the access to abortion. And on top of that, we see how many group organizations like doing birth justice, like working, trying to make sure that obstetric violence is taken away from like those rooms. Like we see this pushback from big hospitals, from big corporations, because I call them corporations, because if you're trying to like deny like community organizations trying to come together to tackle an issue that is like facing our communities, that is violence. And like you should be able to work with us. But instead, we see all these big organizations like literally not working with community-led organizations trying to advance as somehow making sure that our women are safe when they give birth and to stop maternal mortality. We all need to work together. And this is my thing. Because when I see a midwife or a doula that is not allowed to go into a hospital with a person that she has been working for months, making sure that she's safe and taking care of that, that is violence, you all. And when we are not allowing those people to make sure that they are like making decisions upon their bodies, that is violence. So we have to work holistically. We have to work together in order to make sure that our woman, Black, Indigenous woman of color, stop dying at birth. And that this maternal health crisis in the US needs to stop. And that starts from these big organizations of health that have the most resources a lot of times to take care of people. But guess what? Racism is a thing. And doesn't allow them to take care of us because of the inherent racism.
Thank you, Karla. I need a minute, but I'm always so fired up when I get a chance to talk with you or to hear you. And so much in there of what you shared with us, and the couple kernels I think that I hope people will walk away with. One would be how intrinsically linked this conversation we're having about coverage bands is to just health and dignity overall. And that if someone considers themselves an advocate for racial justice or maternal health, then you do need to care about bans on abortion, whether it's the bans that are saying early in pregnancy you can't get access, or these health coverage policies that were absolutely designed to target low-income people to take away services. Those are your issues. And if you're an abortion access advocate and you're not also standing up and speaking out for maternal health and for racial justice and to dismantle white supremacy, then you're not getting the job done. So that's something that I hope hearing Karla and being here with us today, folks will walk away with. And I do also really want to thank you for naming that you had an abortion, because it is so important to destigmatize talking about abortion. So I will follow your lead, and Karla and I are friends as well as colleagues. So she knows I also had an abortion. As a mom, I've got my kids in the next room. I'm waving at them to keep them away from the conversation. And so it is important to think about that. Karla's naming what it looks like when you need an abortion and you decide to have that care and it is pushed away, the lengths that people have to go to get that money, to get that safe care, and to literally put their lives at risk. And then I feel such gratitude to providers that when I needed an abortion, I had safe care in Maryland. I had health insurance who would cover it. There were only a few very quiet protesters in front who must have seen from my facial expression they should stay 10 to 12 feet away, and they did. But that isn't the experience that most people have. And so whether people are called to action because their experience was without the dignity and safety and compassion that they deserve, which is what Karla had to endure, or especially someone who had such privilege that they do have the experience of compassionate, affordable care, no matter what, it's time to step up. And so I hope folks will hear that as well. So today we talked a lot about some of the policies around barriers, but when we're thinking about supporting providers and enhancing access, there's some other things that don't always get addressed. And I'm wondering, Julie or Jen, if you want to address, and that's that you may have had access to great training at Brown, but what we're seeing around the country is there's really a lack of access to training for people who want to be abortion providers because of the politics, and medical schools are literally feeling threatened and cutting this training out of their programs. And that is a barrier too, as we see the average age of providers increasing and more folks who are retiring. And so then there aren't enough providers. Clinics are closing, people can't afford care, and there aren't enough providers. Would either one of you be able to speak to that?
I'm already unmuted, but Jen, if you want to jump in at any point, please. So speaking from personal experience, I had to intentionally seek out a residency that would help train me to do abortions. And then even within that incredibly supportive residency, needed to spend sort of extra time outside of my sort of core training to do a month of learning the procedures and learning the protocols. So it does take a lot of effort to learn how to do the abortions. And that's just the first step, is learning how to do proper care, how to, adhere to standard of care, know what the complications are and how to manage them. But then sort of the next step is, how do you take that into practice? We've been seeing so many laws go into place that restrict things on the provider end, from specifying the exact width that a hallway in a clinic needs to be, to requiring that a provider have admitting privileges to a local hospital, when honestly the risk complication for first trimester abortion, which is I believe more than 90% of abortions are done in the first trimester, the major complication risk that would need hospitalization is less than 0.1%. So these are incredibly safe procedures, especially the majority of abortions that are provided, safer than most other things that we do in medicine. Honestly, I prescribe medications every day that are riskier than mifepristone and misoprostol. But there's been so many laws imposed upon clinics and providers that pose a barrier to actually providing abortions in the outpatient world. So actually doing abortions in a primary care clinic is kind of a revolutionary thing right now, because so many small private clinics or primary care offices have been restricted so heavily that surmounting the barrier of just the malpractice and outfitting the clinic to literally physically meet the recommendations is oftentimes too high of a cost for an organization to take on. And I think I'll echo what Karla brought up earlier, is that most of the time these organizations are run by wealthy people with a lot of privilege, most of the time white men. And not to say that there aren't white men that are our advocates, but the majority of the time when we come up against these barriers, it's because an organization isn't willing to sort of take those steps. And also because as physicians, I don't think that historically we've been doing a good enough job of advocating for ourselves to make sure that we don't have these risks imposed upon us, and that we're not limited in providing necessary, essential, routine care to patients who need these procedures and medications. Yeah, Jen, do you have anything to add to that?
Everything that you just said is totally spot on, and I would say the other piece to this is that most FQHCs are federally funded. And right now the federal government says that you can't do abortions in your healthcare center. So that's the other piece to this puzzle that really limits providers who are able to provide this service and provide access to patients who want this service and who need this service to a place that they can't do it. And I think that's a big struggle specifically in Rhode Island right now. I can't tell you how many providers I know who really want to be able to provide this service to their patients in the primary care setting, and their employer won't let them. And so I echo Julie in that the primary care facility is the place for this to be done. I feel really strongly about that because it's part of essential healthcare. The same place that you go to manage your other, your chronic health conditions is the same place that you go for your reproductive services. So
with the person that knows you best, right? And
right.
And I think just to go back for a second, a lot of patients who go to FQHCs for their primary care already have access to care barriers, whether it be socioeconomic or minority status or language barriers to care. Like, these are people who are already who are already more likely to be at a disadvantage. And so it is contributing and perpetuating systemic racist cycles of poverty and generational poverty to limit federal funding for abortion as well, and to limit FQHCs from providing abortion care. And that, I think, just reflects back on a lot of the really powerful points that Karla brought up, which is that limiting access to abortion is perpetuating systemic racism and is perpetuating cycles of poverty that are more strongly affecting minorities, racial minorities, and honestly, people of other minorities as well. I just read a research study this morning where transgender and non-gender conforming persons are more likely to try to self-manage their own abortions and to not seek out the supervision of a healthcare professional because of the cost and coverage and access to care barriers and stigma that they face as well. So we're talking about equity and we're focusing on social justice and racial justice today, but I think it's also worth saying that there are other minority groups as well that are at a disadvantage, other disadvantaged groups, I should say, that are being affected by not having access to this essential healthcare.
Absolutely. And you were talking about FQHCs, federally qualified health centers, and these federal limitations that exist. And we kicked off this conversation talking about the Rhode Island and federal policies that specifically impact Medicaid. And it is so important to name that these are all programs that are supposed to be closing gaps in access to healthcare. So these community health centers are supposed to be there for populations that otherwise would not have affordable access to the full range of care, and limitations are put on different contraceptive methods, and funding has been cut. So a lot of rural health centers either can't meet the needs or are closing, and abortion has been siloed out. A lot of community-based health programs because of politics, nothing to do with health or safety, or even in this case, funding, other than funding being taken away with a political agenda of making abortion harder to get. Medicaid was created, and we had a whole panel earlier in the week on the Women Project that was about the Medicaid program, which is supposed to meet the needs of low-income people. And so when we say undocumented people can't get care in Medicaid for contraception, which Karla is dealing with, or we say in many states, including Rhode Island, you can't use your Medicaid benefits for abortion, we are taking away health options and health decisions from people who already struggle to obtain care within programs that were supposed to address those challenges. So they're not only insulting, but absurd policies, because they're really undermining the very goal of those programs. And one thing that, Julie, that you mentioned was also, and I saw that news story too, that transgender and gender non-conforming people are self-managing abortion. And in this case, not in a safe way. So not with necessarily a trusted health professional and access to the proper medication protocol, but doing so in desperation, either because of financial barriers or a lack of cultural competence within the medical system. And, Karla, I know that this is something that Kalora does a lot of work around in terms of, it's not just the barriers that exist. Can you get to a clinic? Do you have a clinic? Is there a provider there? Can you afford it? But it's also, will that provider be culturally competent in treating you as a whole person, depending on who you're showing up as? Could you talk about the importance of ensuring cultural competence in abortion provision?
Thank you, Morgan.
And reproductive health care?
Yeah, thank you for saying that. I'm going to start with this story. No abortion specifically, but it kind of like it kind of shows, correct, a little more about the lack of cultural competency that a lot of our providers have, which is about training, and it's about like making sure that they have the tools that they need in order to provide the service that we need, correct, period. So it was in probably like 2007, 2008. I was still working in Southwest Colorado, a rural community in Colorado that I worked there and lived there for 11 years, work with the immigrant community. So a documented woman comes like, can you help me to go to the clinic and get my birth control? I'm like, oh, sure, of course, I want to make an appointment. So made an appointment, like went with her so I could translate for her. I was like, that was the first time that she was going to a health center so she could get her like whatever proper medication she needed to take care of her body. So we go there to this center and no even like, okay, what's your name, whatever, blah, 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 demographic things, but not even like, okay, like tell me your story, like what are the things that you like are concerned about, like what would you prefer, like what have you talked about it, nothing. Okay, let's put you in depot. And I was like, whoa. Let's pump the brakes here. So you haven't talked to her about all the options that she has, and you're just gonna put her in depot right away. Like, I am an advocate, so I am trying here to make sure that she knows what is that, and that you are providing her all the information she needs so she can make that decision about what is the best birth control for her. Because if that doesn't work for her, then can come back to you and change it if she needs it, but you cannot impose into what she needs to use for herself. So, and obviously the provider didn't appreciate what I said. And I know that they came from like, unfortunately, racist views of like, oh yeah, she's a Latina undocumented, they're gonna have a lot of babies, let's put in this. That's the reality. Because of they sterilize us, or they are trying to put us in high hormone things, so because we don't need to have more babies. That's the reality that at least in like Latinx communities we face when we are trying to go to providers. So on that day, in like working in the abortion rights movement, when unfortunately, like I was working with an undocumented young woman under 18 years old that didn't speak English, that didn't like Spanish was her second language, and went to, to try to get information. And somehow it seems that there was some miscommunication where it was communicated to her that she, like this was gonna be brought up to the police. And it's like, no, that's not happening. And that's when we kind of like came and like helped her through the process. Needed to show up with her and all this stuff, correct? So it's like, we need to make sure that those obstacles of cultural competency and language barriers are also part of the conversation. We are doing a research right now, Color and other amazing organizations around the country, a few of them, about like obstacles, correct, to youth to access abortion. And one of the stories that we came across is that a young person at the end of the day didn't have her abortion because the providers that she was going to get an abortion didn't provide her the right information. And then she just like, the time kept passing and she couldn't even like get the money, and she ended up like dropping out of school and having the baby. So, which is like, you know, she didn't want to happen that, but that it ended up happening because still we see this, like this kind of like things that has to work better. And I know that, you know, it could be like isolated cases, but let's come back here and say, like, those isolated cases, they are people and they are real stories and real people's lives. We haven't given the right information, like the right, I don't know, like service, customer service, whatever you want to call it. I don't know, like competency, like whatever it is, to make sure that this person understands or has all the information that needs in order to go ahead with their with a decision that they made. And that is, yeah, I can't, it kind of, it feels like it makes me so angry when I hear like, well, that could be an isolated case. You know what? I could have been that isolated case. I could, because I came to this country with no speaking any English, being in a relationship that was not healthy. And if I got pregnant, then what would have happened to me? I could be the isolated case, and it could totally put my life completely backwards. So we need to stop, even within the healthcare system. We need to stop saying isolated cases, because these are true people's lives and stories. And if you can go back to sleep like, oh yeah, it was an isolated case, I don't know what to say, honestly. So these are the things that we need to think about when we are trying to like work within a culturally and linguistically competent environment, because the needs of our communities are completely different now, and we have to adjust to those because we are treating people, and we are not should be undignified like that way.
Thank you. That's so important. The whole concept of an isolated case, which is really interesting way of just trying to disregard some of the most horrific examples of the healthcare system just not meeting the needs of people who are pushed to the margins. And the fact that these are real people, and that any one person facing that level of indignity is too many. Though we know that the chances are that's just the person that had enough connection to an advocate like yourself for their story to be told. It is not that it's the only story that's an example of the many injustices that exist in the healthcare system right now that are created by our political system. And that's where it's important to think about, you know, what's really coming out in this conversation. That policy change is important, and we've got to be working to get rid of all these limitations, whether it's the barriers to the ability for providers to get trained, or it is the health coverage limitations, whatever it might be. But policy change isn't the only thing we need. We need systemic change for the kinds of hospital issues we talked about, and the whole way that health insurance and health is provided in this country. And we absolutely need culture change, because that's what's creating what Karla was just talking about, and that's what's creating stigma on abortion. And, you know, Karla, thank you so much for naming young people's access to abortion, because it's a topic that is very rarely discussed. Thank goodness in recent years, we've really dug in on this economic and racial justice conversation about coverage bans that were really ignored for a long time because they've been around since 1976. So think about that. Roe in 73, in 76, huge swath of insurance programs taking away coverage. Didn't talk about it for a long time because it was just seen as politically difficult. Finally, we've got this amazing women of color led, RJ led movement, but young people still aren't being talked about. Either respect for young parents, so not approaching teen pregnancy is some terrible thing that must be solved, but actually supporting young people. and also ensuring that young people have access to abortion when they want or need care. And so as movements, and if we're going to talk about abortion access and respect for abortion providers and meeting the needs, thank you for naming young people, because that is often ignored and we've got to do better. You know, whether it's in Rhode Island, we have forced parental consent. In Colorado, there's forced parental notice. But if you're a young person who needs an abortion and for whatever reason feels like they can't turn to their parent or guardian, then whether you have to notify them or ask for consent, there's not a big difference. Most states have these barriers and they really aren't being dealt with in any large organized way. And we've got to be taking that on if we're going to even come close to talking about true abortion access for all. So thank you so much for naming that really important issue. So this has been such a conversation today, and I hope we've left people with a lot of things to consider and to learn more about. I hope that folks will connect with either the Rhode Island or their local Academy of Family Physicians. I hope everyone will connect with the Women Project if you already weren't, and certainly with CALOR, again, the Colorado Organization for Latina Opportunity and Reproductive Rights, because so much great work happening with health professionals who are trying to advocate for real access and health equity, and with groups like CALOR and the Women Project, who are having these conversations, are talking about young people's access and health coverage bans. These two groups are the real deal. So you should be engaging, getting involved, donating lots of money, lots and lots of money. So we're talking about celebrating abortion providers and closing gaps in access. I'm going to provide a couple next steps at the end, but before that, other than lots and lots of money and love for these groups, any final comments? If you had one more little nugget of wisdom, inspiration, motivation to say to the folks who are with us, what would you have to say? So we'll just go in the order we presented in. So Dr. Buckley, Jen, what do you want folks to know or do?
Oh, that's a loaded question.
Yes.
If there's, for me, if there's one take-home point for this particular live stream, it's to reflect on the current Medicaid coverage in Rhode Island, and to reflect on the fact that right now Medicaid will cover your pregnancy, your delivery care, and your new baby care, but they will not cover your abortion. And so I think we just all need to sit with that, to think about it, what is our insurance telling us with that? And what are they potentially forcing someone to do in that situation? And then the other thing, so it's not, that particular point isn't just unfair, but it's also unfair that wealthier people with a uterus who have private insurance actually can make that choice. So that would be the thing that I want everyone to just really think about and really try to use to pushing Rhode Island to make Medicaid cover everything.
Super appreciate that, Jen. And that is an important point, because when the Reproductive Privacy Act was passed in 2019, some of the restrictions that were still on the books related to private insurance were dealt with. But the fact that people who use Medicaid, so low-income Rhode Islanders and state employees, the prohibition on their health coverage for abortion was not dealt with. So this is a huge unmet need to make that large effort to protect the right real. So that's the Equality in Abortion Coverage Act in Rhode Island, Senate Bill 267 and House Bill 5787. You can find more information and there'll be lots of opportunities to get involved. I'll provide a couple at the end. And if you aren't in Rhode Island, find out what your state policies are. A lot of states do have similar bans, and then find a local group doing something about it for sure. Julie, what do you want to leave us with?
I want to echo that Rhode Island is behind on this. Our neighbors in Connecticut and Massachusetts and Maine have already passed legislation and approved funding for state employees and Medicaid insured patients for abortion. So get with it. Figure out who your representatives are, call their offices, send them emails, sign on to the legislations and the gosh, I'm blanking on the word. When you get the email and you can petition, that's the word, sign on to the local petitions to encourage them to push forward these policies. And remember that as healthcare providers, you're also advocates for your patients. These issues are inextricable from things like health equity and racial justice. They are the same thing. When we deny people access to care, to essential coverage like for services like abortion, we're perpetuating systems of racism, colorism, xenophobia, and denying coverage to people who have other barriers to care, new immigrants, people with language barriers. It's really important that we care about all these things and that we advocate for our patients on behalf of our patients and on behalf of ourselves to make sure that we can provide this care.
Absolutely. Thanks, Julie. There's a way for everyone to get involved, even in this time when maybe we can't head over to state houses and fill the halls like we would often do. There's virtual testimony opportunities. There are definitely emails and calls that can be made. Phone calls, so powerful for a legislator to hear from their constituent about an issue they care about. There are a lot of ways to get involved. And so it's one of those, if you really care, if you spent the time with us today, you spent an hour with us today. So if even once a week in our really busy lives, you could set aside an hour and find a few things you could do. If everyone who really cared about abortion access, racial equity, health justice did that, just imagine what we could do together. And I know Karla believes in that. And Karla, what else do you want us to know and do?
Well, first things, I want everyone to appreciate abortion providers and honor them because they do a really hard work. And a lot of times with protesters outside of their clinics, harassing them. And no one should do their work, the work that they do, that they are passionate about, that is about protecting people and their health in that type of environment. So thank you, and I honor you. So everyone should do that. And yeah, get with your state, organizations, fight for abortion, access to contraceptive, all reproductive health services and basic healthcare services. As what we have seen in this pandemic, how it's people of color are the ones that hit the hardest right now during these times. And that is because all the things that has happening systemically for us to try to restrict access to healthcare, and abortion is one of them. Just one little thing within the whole variety of services that we are restricted just because our socioeconomic status, our immigration status, our skin color, or the way that we express our gender identity. So thank you, everyone. Yeah.
That's great. Thanks, Karla. So again, if you want to specifically think about how to engage on some policy change that could make a real difference, then you've got the Women Project working in Rhode Island to get rid of the health coverage bans. You can jump on and find out more about the Equality Abortion Coverage Act. You can absolutely, and I hope you will, support Karla's efforts to advance Senate Bill 9, which is legislation that would ensure that the Colorado State Medicaid program will provide contraceptive access for undocumented people and also expands access for people who use Medicaid to getting a year supply of contraception at a time. And so if someone has already gone through that whole process, screened for health and contraception is appropriate for them, they found the method that works for them, they can get a year's supply. So that barrier of trying to get out there every month or every few months, these sort of arbitrary requirements that insurance companies will put on sometimes. Well, for Medicaid folks, so these low-income people who might face transportation barriers, taking time off work to have to go get that supply, you can get a year at a time, and countless studies have showed how important that is. So Senate Bill 9 is actually going to be heard on March 22nd. So if you want to help shout out support on social media, provide a letter of support, hint, health professionals, you want to submit some testimony, you want to jump on in virtual, show your face in one of these little Zoom boxes to testify in support, Karla's your girl. Karla will get your back on expressing support for that. But even if you're not in Colorado or Rhode Island, there are amazing policies being advanced in your state that get at the kind of issues that we are talking about today. So find your local group. I would also say to think about donating to your local abortion fund. I've got my Everyone Loves Someone Who Had an Abortion t-shirt on today. I like to, it's a little self-love too, right? Because I had an abortion. But it also is such a really substantive way that you can help ensure abortion access. Because when people are being denied coverage because of these ridiculous bans on health benefits, abortion funds are stepping in and filling the gap. So there's an abortion fund in most states, in some more than one if it's a large area. So find your local abortion fund. So I'm regularly donating to the Baltimore Abortion Fund. I know that there's WEF in Rhode Island. I think it's the Freedom Fund in Colorado. I'm also a huge fan of Fund Texas Choice, which works really hard down in Texas and also provides travel assistance. Think about the geographic expanse of Texas. It isn't just being able to afford the services. If you have to travel because there's only a couple clinics in a giant state and so many have been closed, that can be a barrier that abortion funds are also helping with. And so think about whether you can give, $5, $500. I always say that because, for some people that's real. Give it to your local abortion fund. Give it to your local group like the Women Project in Calore, doing the hard work on the ground. Find your Academy of Family Physicians chapter. Give them some love. Send a love note, thank you note to your local abortion providers, whatever you can do. For folks who are hooked into the Women Project, on the March 18th, we've got our next Well conversation. This is our conversation where we bring together folks working for change in Rhode Island. So March 18th, it'll be streamed here on our Facebook. And that is going to be about the doula bill to make sure that folks who use Medicaid have doula coverage. So birth workers to support maternal health and address that maternal mortality crisis that Karla was talking about. There's going to be a local dancer, artivist who's using art to push change. There's going to be a bunch of great folks. I'm trying to remember them all, but those are the two. Those are your teasers. And there will be a hearing on the Equality Abortion Coverage Act coming soon, so stay tuned. But you've heard enough from me. You hopefully were super inspired by my fellow panelists. I know I was. So I'm going to go donate to my local abortion fund. I'm going to go check in with my kiddos. They often have questions when they've heard me talking about all this. I'm going to answer their questions so we can educate the young people to be part of this movement. And I hope you're going to follow the groups that were involved today, donate to the groups that were involved today, and set aside at least that hour every week to get active and stay active. Dr. Buckley, Jen, thank you. I always like to give you your title. You worked hard for that title. Dr. Blossom-Hartley, Julie, thank you. Karla Gonzales Garcia is working so hard out there in Denver. Love you all. Big hugs. Let's go keep fighting the good fight, and let's always celebrate abortion providers. All right. Have a great day, everybody. Bye.